I now have the pleasure of just reintroducing our speaker from last week for our Q&A session, Dr. Dan Weaver, who received his medical degree from the University College Cork in Cork, Ireland. He completed his internal medicine residency at UK and joined the Division of Hospital Medicine in 2015, where he is now an associate professor. In 2018, he helped develop the Addiction Consult Service and Education Service at UK and is one of those physicians that rotates on ACES service. Additionally, he is an associate chief within the Division of Hospital Medicine and is board certified in internal medicine and addiction medicine. So with that, we welcome back Dr. Weaver, and we'll turn over the screen to you.
Great. All right. So these are the learning objectives from my talk from last week. Hopefully everyone afterwards recognized that alcohol consumption is common, and with that also alcohol use disorder is common. We discussed how to diagnose alcohol use disorder during a hospitalization. We reviewed management techniques on alcohol withdrawal. We discussed risk factors for severe alcohol withdrawal and also talked about techniques to manage such. And that's I think, important point as well. I'm an inpatient doctor, and so I know a lot of people don't always on the session here aren't inpatient, but there's a important delineation of when someone needs to come see me to detoxify versus can be done as an outpatient. We reviewed medications for alcohol use disorder, and then hopefully you guys all recognize that substance use disorders are chronic medical conditions. So I was asked to just do some highlight slides. And so this is my first highlight slide, kind of giving us a recap of how common alcohol use disorder is and the overlap between other substance use disorders. I couldn't find a great graph about how much opioid use disorder and alcohol use disorder correlate, but you can see here, this is from SAMHSA, from the 2021 National Survey on Drug Use and Health. This is done every year. The results come out a couple of years later. And you can see that there's nearly 30 million people in the United States with an alcohol use disorder, which encompasses 64% of people with substance use disorders in general. So by far and away the most commonly used substance. And then there's an overlap of people that have both an alcohol use disorder and a drug use disorder, about 7.3 million, which is about 16% of people with substance use disorders. This is another, I think, very important slide. I talked a lot about economic impacts, but I think really when you're talking to your patients about the implications of alcohol and alcohol use disorder and chronic alcohol use, it's really talking about all the adverse health effects. And often we do not discuss this properly with patients. And I think when you do discuss it and educate our patients about the effects, a lot of them are quite surprised. Everyone or most people recognize you can get liver cirrhosis from chronic alcohol use, but they don't realize all the other effects. And so this is from the CDC, which is the alcohol attributable deaths in the United States. And so they split it between acute causes of death due to alcohol and then chronic causes. And so I think it's important to talk about those two different buckets when you're talking to your patients about their alcohol use. In terms of acute causes, there's things like acute alcohol poisoning, overdose. A lot of people that have an opioid overdose also have alcohol in their system. There's motor vehicle accidents associated with alcohol use. And a lot of people, after you say that, they're like, oh yeah, that does make sense. Death by suicide is quite underappreciated in terms of, alcohol is generally in the system between 30 and 40% of people that die by suicide in the United States. And so alcohol is a depressant. It definitely affects people's mood, and that's one of the theories between why it contributes to it. And then accidents while people are intoxicated. There's also then the chronic causes. And so I guess I should have mentioned the graph. Those numbers are deaths. And so overall chronic causes plus acute causes leads to 140,000 deaths in the United States. So a lot. Chronic causes, liver disease, that's well known. What's not so well known is malignancies. And so it's pretty much become more and more mainstream within the medical community about how physicians and nurses need to advocate more about or discuss with their patients more the effects of alcohol and the risk of cancer. And essentially every single cancer, you're at a higher risk when you drink alcohol of obtaining that cancer. Definitely, it's been well known, a lot of the mouth cancers, esophageal cancer, stomach cancers, and then liver cancer, hepatocellular carcinoma. Really, more and more, all cancers are associated with alcohol. And that can make a pretty profound statement when you're talking to your patients about it. Heart disease and stroke. You definitely see people who get into the hospital with heart failure because of their chronic alcohol use, or hypertension, high blood pressure. Those things, high blood pressure, can lead to coronary artery disease, which can lead to heart attacks, can also cause thickening of your blood vessels and lead to strokes as well. So those are hitting the big causes of death in the United States, right? Heart attacks, strokes, cancer. Liver disease, that's pretty well known, I think. Pancreatitis, definitely is the two most common causes of pancreatitis are alcohol, as well as gallstones. So alcohol is a big cause of pancreatitis. Pancreatic cancer, she mentioned as well. Pneumonia, a lot of pneumonias can be associated with alcohol use, and you're more likely to get a pneumonia if you have an alcohol use disorder. Your cough reflex is impaired, so you're not clearing the saliva in your mouth. If you're intoxicated and vomit, you could aspirate stuff into your lungs or vomit into your lungs. Seizures, if you have a seizure disorder, you lower your seizure threshold. That means you're more likely to have a seizure if you drink alcohol. And then people also have alcohol withdrawal seizures. And there's a lot of mortality associated with seizures. People that have a seizure disorder, it significantly limits your lifespan. Low infant birth weight. So if a pregnant woman drinks alcohol chronically while they're pregnant, their infant is more likely to have low weight, which has effects for the rest of that infant's life, and preterm birth as well. And so a lot of important health outcomes due to chronic alcohol use that are unrecognized in our society. I think part of it is because it's so socially acceptable to drink alcohol on a regular basis, as well as you don't necessarily need to drink alcohol to the level of having an alcohol use disorder to still have adverse health effects because of alcohol, if that makes sense. And so it's socially acceptable to drink 2 drinks a day, 3 drinks a day in most social circles, but that can adversely affect your health. And it's been a call for physicians to be better at educating everyone about that. My other slide is the DSM-5 for alcohol use disorder adaptation. This is similar for all substance use disorders: cravings, loss of control, and consequences due to your substance use. And it's scaled on a mild, moderate, severe based on those numbers. Certainly during other sessions, you guys have probably been shown the DSM-5 criteria. This slide is I thought it was another important slide because it's the neurotransmitters of how alcohol affects your brain and why people go through alcohol withdrawal, and why some people, because of that alcohol withdrawal, need to be hospitalized and unfortunately see my face. And so I can review this slide real quick, where you have you have exposure to ethanol. And this little yellow receptor is a GABA receptor with the alpha-1 subunit. And so you have enhanced inhibition because the GABA inhibits someone. And then you also block the excitation of this other receptor, the NMDA receptor. And then you have someone that's intoxicated. And so that's when people drink alcohol, they get intoxicated. That's what is happening in their brain. As they chronically expose their brain to ethanol or alcohol, their alpha-1 subunit kind of shifts to the alpha-4. And so you have reduced sensitivity to that inhibition by GABA, as well as your body creates new receptors, new NMDA receptors to kind of control the excitation. So you're still, and that's kind of when people have tolerance. So you know, someone that drinks 1 beer and is intoxicated, but if they continue to drink 1 beer, this is what's going on in their brain to not get intoxicated after that one beer. But then when you remove the ethanol, you have that loss of inhibition on the GABA receptor, and then you also have that uncontrolled excitation on the NMDA receptor, and then you have the alcohol withdrawal syndrome. These are the this slide is the different signs and symptoms of alcohol withdrawal, as well as the timing. Mild is early, which makes sense. 6 to 24 hours after their last drink. They experience anxiety, tremor, insomnia, headaches, GI upset. Early also, about 12 to 24 hours, you can have alcohol hallucinosis. And then as the time from your last drink increases, you have more or worsening symptoms to moderate to severe. And then it can also progress to alcohol withdrawal delirium. And so that's just a kind of review of the timing of the alcohol withdrawal syndrome. And that's why a lot of patients do require admission to the hospital to detoxify. I think this is an important slide for you guys because I know a lot of people don't practice on the inpatient side. So when do you need to send someone to the ER to get detoxified versus someone can do it with their primary care doctor? There's something called the PAUSE score, which is on MD Calc. It's a prediction of alcohol withdrawal severity scale. If they have a history of prior bad alcohol withdrawal with delirium or seizures, they should not detoxify at home on their own. They should detoxify in the hospital. If they had numerous prior alcohol withdrawal episodes, it can continue to get worse each time, and that's the kindling effect, and they probably should need to be in the hospital to detoxify. If they have other comorbid illnesses, they should probably prompt a hospital evaluation. If they're older, geriatric patients, if they drink a lot for a long period of time, of course, if they have seizures, they should go to the hospital regardless if they're withdrawing from alcohol or not. Marked autonomic hyperactivity. Now that's hard to judge if you're not doing vital signs, but high blood pressure, really bad tremor, high heart rate, those types of things, they probably should seek medical attention. If they have a codependence on another medicine as well, including opioids, benzodiazepines, or barbiturates, or if they have a high CWA as well, so they're already withdrawing, they probably should go to the hospital. This slide is reviewing the different medicines that we use to treat alcohol withdrawal. Benzodiazepines, they work on that GABA receptor. Phenobarbital works on the GABA and the NMDA receptor. So I can go back to this slide and you can see benzodiazepines work on that orange yellow receptor. Phenobarbital works on the red one and the orange yellow one. And that's why we use those medicines to help detoxify patients. GABA-sensitive anticonvulsants can also be used as an adjuvant, but usually not safe on its own unless it's very mild alcohol withdrawal. So think of like gabapentin is probably the most commonly used. I think we're getting close. This slide is medications for alcohol use disorder. So after someone detoxifies, these are from the ASAM Alcohol Use Disorder Resource Guide. And these are the 5 medications that are used probably most commonly for alcohol withdrawal. Or sorry, alcohol use disorder, not alcohol withdrawal. And so there's naltrexone, which can be given orally and intramuscularly. There's acamprosate, disulfiram, gabapentin, and topiramate. There's other ones that would be off-label. The first 3 are the ones that are FDA approved for alcohol withdrawal. The other 2 would be used off-label. I think I put this slide out of order, but it's kind of interesting. When I was doing a little bit of research for questions, this paper came out yesterday. And so this is a review of the pharmacotherapy for alcohol use disorder. It's a systemic review and meta-analysis in JAMA. It's pretty interesting. The number needed to treat in my first talk was a little bit different than what they came up with this one. So they found in this one, the number needed to treat for one person to return to any drinking for acamprosate was 11, which is pretty good. Number needed to treat was 18 for naltrexone orally. And then return to heavy drinking for naltrexone was 11. So also pretty good numbers still. So the new meta-analysis, it holds up similarly. So this is the first question. There have been a few studies using spironolactone for alcohol use disorder. Do you have any information or insight into this possible treatment? Honestly, I hadn't heard of using spironolactone for alcohol use disorder. A lot of times in my practice, patients have not tried anything for their alcohol use disorder. And so usually I stick with the FDA approved medications just to try something. I did look into this. The research, I think based on the research, it was reaffirming that I didn't find a big gap in my practice. There is some retrospective studies. The way they researched it was they looked at was there a decrease in alcohol consumption when people started drinking or started spironolactone for some other reason. So I think one of the big studies was out of Kaiser, where they started implementing like an audit C. So they started looking at people's alcohol consumption and having brief interventions. And so that was something that was implemented in the Kaiser system. So people asked more about alcohol, which is great. That's what people need to do, is ask more about patients' alcohol consumption. And then they looked at the numbers when people asked of their follow-up visits. Did it change with initiation of spironolactone? And it showed that it did. I think one of my critiques is that when a physician is starting spironolactone, there's often significant medical illness that's associated with you starting that medication. And the main ones that I start spironolactone for are decompensated liver cirrhosis. And so that's a significant medical condition. And so you start spironolactone along with another diuretic to keep fluid off their belly that people get with alcohol or with liver cirrhosis. And so is that a confounder to reducing your drinking? If someone just got a diagnosis of liver cirrhosis or decompensated liver cirrhosis or having a sick liver, if you're using patient-friendly terms, would that have an impact or reduce patients drinking? I think yes, probably. And some of the other studies kind of have similar ideas. So I don't know. There was another study in the VA that kind of had a similar, it kind of just reviewed with initiation of a medication, like with initiation of spironolactone, did drinking go down? And the answer was yes. I guess my critique is, well, they probably had a reason to start spironolactone that could also make an impact on someone's drinking, like liver cirrhosis, heart failure, that type of thing. I hope I answered that person's question. I guess I don't know if the person is on the call or not. I guess I'll wait. Did anyone have any follow-up with that? Okay. I'll move on. Are you familiar with the Sinclair method? A person takes naltrexone 1 to 2 hours before drinking to block the brain from releasing endorphins in an effort to decrease the urge to drink. What are your thoughts? I think it's an interesting idea. The recommendations from the American Psychiatric Association, SAMHSA, and the way the medication is FDA approved is for daily dosing. I think in general, as a physician, I would have concerns about compliance, right? So can someone get triggered to drink alcohol and then remember to take naltrexone and then wait 1 to 2 hours? That would be challenging. Um, you know, would you say disulfiram or antabuse could be used in that same scenario? Probably. If I looked at the research, most of the research I saw was by Dr. Sinclair, and there wasn't any other studies to back up. It was kind of a theory, I think, more than a validated tool. So I was intrigued and see if there. I saw did some research to see if there was any evidence behind it, and I think some of the thought behind it could work, but I think in practice would be quite challenging. In all honesty, it's hard if you take away even all substance use disorders to get compliance with medications for blood pressure, diabetes, and all that, and so it's really hard for people to remember medicines. And so I think in practice it would be quite challenging to do that. Does that answer that person's question?
Dr. Weaver, this is Lisa. Yes,
Yeah.
it does. That was my question because I facilitate smart recovery meetings for family and friends, and it came up through the smart recovery
Okay.
as kind of a recent type of treatment. So I was curious because I've not heard about that at all, and I was wondering. So
It looks like it's actually old. I think the original research was 20 years ago, or the original, not, it wasn't research
okay.
really. It was like a theory.
Okay. Okay. Yeah.
I also do like inpatient hip fracture service. And when people have low vitamin D, you need high dose vitamin D once a week. And I worry, thankfully a lot of those patients end up going to some sort of rehab, physical therapy rehab, or a nursing home. But I worry when people go home, are they going to remember to take a medicine once a week or not? And so I think it would be very challenging to take a medicine right before you're about to drink alcohol,
Yeah.
especially if you're going to go on a bender type thing.
No, makes sense. Yeah. Thank you.
Okay. How long will someone need to be on a medication for? What is the criteria for discontinuing medication? This is a good question and can be challenging. There's a range, and it depends on the severity of the alcohol withdrawal. I'd say a minimum of 36 hours for acute withdrawal with medicines, but it definitely can be longer to like 96 hours or more. Sometimes toward the end, where you're not sure, it depends on how conservative or aggressive you can be. A lot of it also depends on the medicine that they're on. I didn't include this in my slide, and maybe I should have, but there's the diazepam and chlordiazepoxide, which are longer acting medicines, and then lorazepam, which is a shorter acting medicine. Again, the longer acting medicines are metabolized in the liver, and then those metabolites are also active. So you could feel safer discharging someone on a medicine like that, because if they get a dose now, it's going to be in their system for a couple of days, the metabolites. Whereas lorazepam, it would be less likely. It's not metabolized into anything active. So so there's certainly a range, and it depends on the severity of alcohol withdrawal. What I tend to do is I look at the CWA scoring, which is the way you rate alcohol withdrawal. And if they're consistently below 10, they shouldn't get any doses of medication, and they should be safe to discharge. And so I kind of wait between 12 to 24 hours. They'll still have some symptoms of withdrawal, but won't necessarily need medications. And patients, it's important also to talk to them that, their sleep-wake cycle, they're going to get really bad sleep for the next 6 months even. And it's important to tell patients that so they recognize it and don't return to use. Then, well, I need alcohol to go to sleep. Well, if you allow your brain to recover and heal itself, hopefully it should improve. Now, I should say some people won't ever return to their pre-alcohol use disorder sleep-wake cycle. So I'll pause there to see if that answered people's questions. Is there evidence that long-term recovery rates are better when one takes a medication for alcohol use disorder? This is a great question, and I don't think we have great evidence or answers for you. I should say that oh, sorry, I thought this was a different question. I had a brain cramp right there. So is there evidence for long-term recovery rates are better with one takes a medication for alcohol use disorder? There's another question later on. That's also a great question. This one is the combined study. So there is evidence that this helps. In the combined study in 2006, patients received naltrexone and medical management had a greater proportion of days abstinence and reduced risk of heavy drinking in a day. For the combined study, acamprosate didn't really seem to change the effect. There's some research showed that there isn't a difference between naltrexone and acamprosate, and both are effective as well. There was an AHRQ systematic review and meta-analysis that showed both of them were good. A Cochrane review of 24 randomized controlled trials found that acamprosate was safe, effective, and had a moderate effect. One study showed that there was no difference in return to heavy drinking with both acamprosate or naltrexone. So I guess the evidence shows that there is pretty good evidence between acamprosate and naltrexone. It's varied depending on the study, and it's not as strong as buprenorphine or methadone for opioid use disorder. And a substantial amount of people do obtain long-term recovery from alcohol use disorder on their own, actually, as they get older. So it's kind of moderate evidence. I hope I answered that question because I kind of was thinking about another question. Actually, it's in a couple slides. Okay. Well, the next question is what I was thinking about. Is there evidence that long-term recovery rates are better when behavioral therapy is integrated into treatment? And so the combined study from 2006 tried to answer that. It was a big study. Over 1,300 patients were included, and they had 8 groups of patients. And so they had medical management plus medication, and medical management was essentially like seeing a doctor and talking to them about the medicines. There is combined behavioral interventions, so like 12 steps, cognitive behavioral therapy, and one other one I can't recall, medical management and medication. And then CBI only, combined behavioral intervention. Everyone in all those groups showed a decrease in percentage abstinence. So even the placebos and all that. Interestingly, and the answer to this question is the combination between naltrexone and the behavioral intervention with medical management. So if you added, so those two together did not improve. And so you showed improvement with medical management and naltrexone. People showed improvement with combined behavioral intervention and medical management. But if you had all three, you did not show improvement. So I think one of the critiques for this, as well as they wrote about this in the paper, and this is kind of the all the groups they had, just to give you an idea. It's quite an extensive study. They all had medication management. And so medication management was included. And so that's when a doctor or a provider spoke to them about their medicines and their alcohol use. Kind of like a quick, I think about it almost as like a quick intervention type thing. And I think it's also, so when someone enrolled in this study, all the arms are less likely to drink alcohol. But I think that kind of proves our point is if you just talk to patients about their alcohol use, it's going to be helpful. And did medical management take the place of the behavioral intervention? Like maybe just someone talking to a patient about their alcohol use was helpful. And so I think this was the one study I found that tried to address that. And I think my answer is we don't have a great evidence that yes, medicine, some sort of behavioral therapy is definitely better than just behavioral therapy or just medicine. But the guidelines recommend all three. It's hard to know how you'll respond. And I think also, like I should say, in the real world, doctors have 15-minute visits for their patients in the clinic. Probably they have more time during this study because of the nature of all research is they have more time and money to spend with patients. And so would behavioral therapy hurt a patient on top of their seeing a doctor for the medicine? I don't think so. So I think maybe the jury is still out. Probably if they were to redesign this study, they would think about maybe we should figure out a way to not have the medical management as a confounder to the behavioral intervention. But it's definitely an ambitious study that they did. But behavioral therapy is part of the guidelines to recommend it, as well as medication for moderate to severe. So I hope that jumble answered that person's question. It was a really good question, and I don't think we have great evidence yet, but I think it's still probably the standard of care to integrate the two. Would you recommend any of the medications for alcohol use disorder in pregnant women? The short answer is no. The American Psychiatric Association recommends not to use pharmacological treatments for alcohol use disorder in pregnant or breastfeed women. There's increased risk with topiramate. There's moderate risk with naltrexone based on animal models, high risk with acamprosate, possible risk for gabapentin. I have never been pregnant myself, but my wife was, and I sometimes occasionally treat pregnant women in the hospital. And it's really, there's no great evidence for using medications in pregnant women, and they're quite limited in what you can use. And I think also, the evidence behind behavioral interventions is pretty strong in it by itself. Again, the combined studies show that a behavioral intervention did result in people reducing their alcohol use. And so I think when you have good evidence of behavioral interventions working, as well as potential harms to the fetus due to medications, that's really why no guidelines recommend medicines for pregnant women. Now, if you get pregnant while on this medication, right? People get pregnant unexpectedly all the time. The biggest risk was in the first trimester, and most of the guidelines recommend having a risk-benefit discussion with the woman about the need for a medicine, because we do know alcohol is teratogenic as well. In terms of breastfeeding, it's limited evidence, but there's potential toxicity for disulfiram, naltrexone, and topiramate. Acamprosate and gabapentin are classified as probably compatible with breastfeeding. It means like the medicine really gets through the breast milk. I should say also that the general public and internists, their threshold to start medicines in pregnant women is usually pretty high, especially when you compare it to like an OBGYN. So if I did have a challenging case, I would talk to one of my fellow colleagues, OB colleagues, and try and get their input as well. But that's a good question. In terms of alcohol withdrawal in pregnancy, we do still treat alcohol withdrawal in pregnancy because alcohol withdrawal is severe and can be life-threatening. So we still would use benzodiazepines to treat alcohol withdrawal. And I unfortunately have treated alcohol withdrawal in a pregnant woman before. So I hope that answered that person's question. That's a good question. My next question is, what is your recommendation for treating patients that have been on acamprosate and they experienced a return to alcohol use? So that's another good question. I usually, and this is in general, when anyone has a return to use, I talk to them about their experience on the medicine, how they felt like it made them feel, what triggered them to use, and do they feel like it helped them? You also want to look into compliance, like was the patient able to take the medicine 3 times a day? And is that going to be an ongoing problem for them? That's one of the challenges with acamprosate. did they, some people say, well, I just stopped taking it and then I went to drinking. Well, that means the medicine might have been effective. They just stopped taking it for whatever reason. So I would really kind of try and delve into the details of, was the medication successful or not? And compliance is an important aspect of that. And I would do the same for naltrexone as well. Another medicine outside of the substance use disorders, if someone's on a medicine for their blood thinners and they get a clot while they're on their blood thinners, I really delve into the details as if they were able to take that medicine every day, what barriers existed for them to take it every day, that type of thing. I get the varied answers. Some people say it's effective and they want to continue it. Some people say it was not effective. Some people want to try a different medicine. And so really I kind of work with the patients and talk to them about their scenario and what they're interested in. I hope that answered that person's question. The next question, are there any government/public health policies that should be initiated to help reduce the harmful use of alcohol? The short answer is yes. What interventions can you do that fights against the alcohol lobbyists? I think a really famous one that we did in this country is raising the drinking age from 18 to 21. With that, there was a substantial reduction in traffic-related deaths, homicides, suicides, and unintentional injuries. And I think also just pushing back those 3 years, we know more that the young brain, like a 21-year-old brain or an 18-year-old brain, is not fully developed. Their frontal lobe isn't fully developed yet. And so you're less likely to expose that developing brain to alcohol. There's also evidence that like high concentrations of like retail alcohol outlets results in excessive drinking. So if you have, a liquor store on every corner, people in that area are more likely to drink excessive amounts of alcohol, which makes sense. Those stores are trying to get their business. And so certain places enact zoning laws or liquor license restrictions in a manner to reduce alcohol consumption in those areas. Some states, interestingly, have government-controlled alcohol wholesale and retail systems. I lived in Pennsylvania for a while, and actually Pennsylvania is one of those states where they have the state-run distributors. And so to get, I think it's hard liquor, you have to go to a state store, and they call it. And so you had to go to the state store. They had limited hours. So essentially it was different than privately run systems, and those have been shown to have lower rates of sale to alcohol to minors, less underage alcohol use, fewer alcohol impaired deaths to use, so less likely to sell to young people. And that can be beneficial. Also, in general, a lot of different countries and different states have increased the cost and taxation of alcohol consumption, and that also reduces the rate of harmful alcohol use. So that's a good question. I think there's a lot of kind of things you can do, but a lot of it reduces increasing costs of things, and I guess a fight against capitalism a little bit. So hopefully that answered your question. But, one could argue, the cost of one drink is about $2 on terms of like government dollars spent. So maybe we should tax each alcoholic drink an extra $2. It's an interesting question. Does anyone have questions about that? Comments? The next question is, do you think recovery rates could be improved if more providers were willing to have a treatment goal for the patient, reduce drinking versus total abstinence? Yes, certainly. There's a lot of evidence that harm reduction can have a substantial impact on people's health. If you get someone to reduce their amount of alcohol that they drink from 10 drinks to 5 drinks, you have a substantial increase in their health outcomes. If you have if you can prove it from 10 to 2, that's a huge outcome. You have less likely to have, and there's evidence for all that. Lots of papers that look at individual health outcomes, alcohol associated injuries, heart function, recovery from heart failure, blood pressure changes. So people's blood pressure improves with reducing the amount of alcohol they drink. Liver enzymes have been to improve. Body weight has gone down. Improvement in liver biopsy results. Improvement in regression in liver fibrosis. Lots of evidence that harm reduction reduces to better health outcomes. And to be frank about it, some people don't want to give up alcohol. And so if you have an all or nothing discussion, then you're going to turn people off right away. And maybe baby steps. Some people just need to say, well, why don't we just try and decrease 2 drinks a day? So instead of 10, reduce it to 8. That could be something someone can buy. Or maybe let's just count the amount of drinks that you drink in a day. Some people don't count. And so then they count, and then you meet with them the next month and talk to them. Well, why don't we try and decrease the amount of alcohol you drink? And they're willing to work with you. And so I think certainly working with the patient on what is feasible is probably the best way to do it. You'll capture more patients that are willing to engage in healthcare that way. And so I definitely think it's important to accept that some people will not stop drinking, but they might accept decreasing the amount of alcohol that they drink. Does anyone have any questions or comments about that? All right, moving along. Can you speak to the impact a supportive family or significant others can have on a patient experiencing alcohol use disorder? Other than that, it's a huge help to have support in any medical condition. I don't think I have a great study to back it up, but there's even 2 different types of behavioral interventions that include family. There's community reinforcement approach, and then the community reinforcement and family training. Both of those behavioral interventions include a family member. And I think my experience working at the bedside, certainly someone with a supportive partner in almost every medical condition is more likely to be successful when you're treating the alcohol use disorder. Now, it's also important to make sure that the person isn't enabling the patient, and that's a confounder as well. And so that might be something you need to tease out when you're talking to the patient and their loved one. It's definitely important to be supportive, but you don't want to be enabling as well. All right. So this is a long one. In recent studies highlighting increases in co-involvement of alcohol in opioid overdose deaths rates, and estimates that 1 in 3 individuals on MOUD also have alcohol misuse. What suggestions do you have for starting conversations with clients I think that might be a typo, clients of opioid use disorder treatment about alcohol use? Effective screening tools if you are a provider. Suggestions/recommendations specific for non-providers working with clients. So I think what I normally do is just ask them in general about their alcohol use. And if they do drink alcohol, oftentimes I find patients with opioid use disorder minimize their alcohol use. Not always. Sometimes people feel like, oh yeah, my opioid use disorder is under control, but I can't stop drinking. But a lot of people minimize their alcohol use compared to their opioid use disorder. And so I really ask them how much. And so I want numbers. How long? When do they start drinking in the day? Walk me through your pattern. Give me details. How does it affect your life, your mood, interactions with loved ones? Those are that's how I ask it. There's screening questions like the Audit C, or the CAGE questionnaire. That's one I learned in medical school. It's, have you ever felt you need to cut down, annoyed when people complain about your drinking, guilty about your drinking, or an eye opener? That can be a tool that's used for non-providers. Audit C is kind of like, how many days a week do you drink alcohol? and then they answer the question. And I think another thing, and hopefully after this talk, you guys feel a little bit more comfortable talking about the adverse health consequences beyond liver disease with alcohol, cancer, overdose risk, cardiovascular health, accidents. And those all have a substantial impact on the health of people. And it's widely unknown. I think, in all honesty, I feel like cancer, when you talk about the big C, people ears perk up and they that all hits home with someone. Most people know someone that has suffered from cancer. And so that's in general how I talk about alcohol use in the setting of opioid use disorder. Other than noting that naltrexone should not be prescribed for a patient who is currently in an opioid agonist treatment with buprenorphine or methadone, are there additional considerations that clinicians need to take into account regarding how alcohol use might impact their MOUD treatment? So I think certainly, I think there's a lot of things to unpack here, actually. With treatment for any medical condition, alcohol use disorder and heavy alcohol use affects it. And so we see it with cancer. I see it quite often in the hospital where a patient has cancer, they need chemotherapy. However, their alcohol use disorder confounds them being able to follow up consistently with the oncologist. I've had patients show up to get chemotherapy intoxicated, and so then they couldn't get their chemotherapy treatment. Patients need alcohol to withdraw from alcohol. And so when you think about it, that can also affect someone going to a Suboxone clinic. If they're going to a methadone clinic, quite often patients get kicked out of a methadone clinic if they show up, but they certainly won't get dosed that day if they have ethanol in their system. A lot of OTPs can, or they have to be able to screen for ethanol use, but often sometimes they do. And so patients get their dose skipped that day, which certainly can affect their opioid dosing or their methadone dosing because they're missing a dose for the day. And so all of those can affect their treatment for their opioid use disorder. And the thought is, right, you have maybe your opioid use disorder is controlled, but their alcohol use disorder is not controlled. And if you have an alcohol use disorder, let me go back here. Where are we? Here, right? Alcohol use, the nature of having alcohol use disorder, it makes a substantial impact on your life. So you have a loss of control and you have adverse consequences because of your use. And one of those adverse consequences is your health or maybe your treatment of one of your other medical conditions. So it has a substantial impact on a lot of treatment with opioid use disorder. Let me get back to that question. All right, I move on. Have there been any studies, potential options for long-acting injectable forms of disulfiram similar to naltrexone or buprenorphine? I have not heard of any long-acting disulfiram. Yeah, I don't think there is any. They're certainly not FDA approved. I did a quick search and I don't think there's any formulation. Disulfiram is an old medicine. It was developed prior to probably long-acting forms of any medicine. It's developed in I think the 1950s. And really there's not a lot of evidence behind its efficacy. So I don't think any pharmaceutical companies really have picked it up to try and make it a long-acting formulation. Is probably one of the reasons. Also, it's a little bit different than long-acting naltrexone or buprenorphine when you think of the formulation. And so I'd be concerned about the ethics of developing that. So let's say, for example, you have this medicine in your system that would make you deathly ill if you accidentally drink something with alcohol or eat something with alcohol in it. So you would call substantial harm. all the time. Whereas long-acting naltrexone, if you have that in your system, you're already detoxified from opioids. So if you use on top of it, you wouldn't get any reward from it. Hopefully it helps you from overdosing, but it doesn't make you sick. And the same thing with the Sublocade or naltrexone, the long-acting forms of buprenorphine. You wouldn't get sick if you use on top of it. So I don't think long-acting disulfiram's in the cards, really. Hopefully that answered that person's question. And those are the questions I received. Are there any other questions?